Good afternoon, everyone. I'm Lori Harada, the Executive Director of Food Allergy Canada, and I'm very pleased to welcome you to our webinar today that is being delivered in collaboration with the Canadian Society of Allergy and Clinical Immunology. Thank you so much for those of you who registered and for sending us your questions about this webinar called The New Guidelines for Introducing Peanut to Babies and What Do They Mean? Before we get started, I wanted to just go over a few things, including some housekeeping things. So first of all, as Dr. Upton, I'm going to introduce her in a minute, but as Dr. Upton talks about the new guidelines, I want you to keep in mind that the presentation is for information purposes only, and it's not specific medical advice for your situation. If you have any questions about your specific family situation, please consult with your own healthcare professional. So before we get started, I wanted to mention that all of you are muted, and so you should be able to hear us, but we do not hear you. If you have questions, you can input them in the chat function, which is in the console under the questions tab. We're going to try and get through as many of your questions as possible following Dr. Upton's presentation. So Dr. Upton is an assistant professor in the Department of Pediatrics and a staff physician in the Division of Allergy and Immunology at the University of Toronto and the Hospital for Sick Children. She also has a cross appointment with St. Mike's Hospital in Toronto as well. Dr. Upton recently joined as the section chair of the Anaphylaxis and Food Allergy section of the Canadian Society of Allergy and Clinical Immunology. She completed her fellowship training in clinical immunology and allergy at the University of Toronto and is currently pursuing a master's degree at the Harvard T.C. Chan School of Public Health. Dr. Upton's interests include food desensitization therapies, allergy diagnostics, and advancing the recognition and treatment of immunodeficiencies. So without further ado, I'd like to introduce Dr. Upton.
Great. Thank you very much, Lori. I really appreciate that introduction. I do want to take a second to mention that, again, many people from the CSACI and from Food Allergy Canada have helped create this webinar, and I'm representing that team today. So briefly, here are my disclosures, and then we'll talk about the agenda. So what we're talking about today is food allergy and testing, and the previous infant feeding guidelines, the new guidelines, which is what everyone wants to hear about, to reduce peanut allergy, the supporting research for that, and then the recommendations that that document has made for parents. We'll also let you have some resources so that you can read further about it if you're interested, and of course we'll try to answer your questions. So I just want to start with food allergy affects everyone, and clearly this audience knows this, but here we have a child with peanut allergy in the middle, and all the areas of life, or at least some of the areas of life, that are affected by his allergies, and really this is a public health problem. I also want to give a bit of background about allergy testing. This audience, again, is very familiar with allergy testing, and so we can look for allergies by skin prick testing and by IgE testing, or a blood test. Skin prick testing creates a red bump when it detects an IgE antibody attached to the mast cells, and blood tests look for this IgE antibody directly. And we all know that there's limitations to allergy testing. The top line shows that the skin tests and blood tests are great at ruling out allergy. And most people with negative tests do not have an allergy. Now some do, but just statistically it is very good at ruling out allergy. Skin tests and blood tests can be positive even when there's no allergy at all. And some people do have positive tests, but they do not have a reaction when they eat the food. And this is why we often need to feed the food to really know for sure if someone is allergic. So why are we focusing on peanut today? So peanut is one of the leading causes of food-induced reactions and fatalities, and it's often a lifelong allergy. And most food allergies are caused by really only a few foods, and learning how to reduce any one of these would result in a reduction of food allergy. So again, today we'll be talking predominantly about the new food allergy or peanut guidelines, which is about the timing of food introduction. And we just wanted to just briefly touch on why do so many people have food allergies, and the timing of food introduction might play a role, or does play a role. But there are other possible causes that we won't really talk about today, but for completeness, I wanted to mention a few. So the previous infant feeding guidelines. So in the 1990s, food allergy was really on the rise, and people wondered what to do. So it makes sense to think, well, why not just avoid eating foods which cause allergies? Typically, people aren't allergic to something they're not exposed to. If you grew up in an area where there's no ragweed, you don't typically have a ragweed allergy. So it seemed to make sense. Another idea was that infants may have an immature gut and just simply not be ready for foods like peanuts. So in the year 2000, the American Academy of Pediatrics issued some guidelines, and they said that solid foods should not be introduced into the diet of infants who are high risk for food allergy until 6 months of age. And furthermore, that milk should be 1 year, not before 1 year, eggs, not before 2 years, and nuts, not before 3 years. But despite these guidelines, peanut allergy continued to increase. And the American Academy of Pediatrics in 2008 said that although solid foods should not be introduced before 4 to 6 months of age, there was no evidence that delaying their introduction protects against the development of allergic disease. So although they no longer said to delay, they didn't explicitly say to eat the foods. And in 2013, the Canadian position statement, which was the CSACI, as well as the Canadian Pediatrics Society, said that there was no evidence that delaying the introduction of any specific food beyond 6 months of age helps to prevent allergy. However, the protective effect of early introduction of potentially allergenic foods is under investigation. 2 years later, the American Academy of Pediatrics said clinicians should recommend introducing peanut-containing foods into the diets of high-risk infants between 4 and 11 months. And the guidelines we're here to talk about today in 2017 said, yes, feed the peanuts, and this goes further about exactly how to do it. So please note that although this document says that it's the guidelines for prevention of peanut allergy in the United States, the Canadian Society of Allergy and Clinical Immunology was also part of drafting these guidelines, predominantly through Dr. Edmund Chan. So what happened? You know, now the advice is to feed peanut early. It's helpful to go through what happened. In 2008, researchers reported that they compared Israeli school children to British school children, and they saw there was a big difference in the rates of peanut allergy. This could not be explained by genetic background because they only looked at people of the same heritage. They looked at Ashkenazi Jewish children. And both Israel and the UK are developed countries, so it couldn't be explained by a huge difference in cleanliness or sanitation or medical practices. The researchers noticed a particular difference in the diets of these kids. So in Israel, they eat a lot of bamba. Bamba is a snack food made from peanuts, and it has a puffed texture. It's actually the #1 selling snack food in Israel, with 90% of Israeli families buying it on a regular basis, and it's often used as a weaning food for infants. Additionally, in Israel, there's no peanut restrictions in schools. So what happens if you feed peanuts to babies? And this was the question that the investigators set out to ask with this landmark study called the Learning Early About Peanuts, or the LEAP study. So the researchers wanted to see, was the difference between these kids in the UK and Israel really the peanut feeding practices? So they made a trial where the timing of peanut introduction was under their control. So if you look, they enrolled infants and they had allergy tested them. And if they divided them into kids that had a little bit of positive allergy tests and kids who had no positive test at all, so a totally negative allergy skin prick test. They then randomly asked them to either avoid or eat peanuts. So meaning essentially they drew a lottery about whether the infant would eat peanut or whether the infant would avoid peanut. And they did that for both of these groups of kids. The kids were asked to continue to do that until around 5 years of age when they had an oral food challenge. So they actually fed the child peanut to see for sure who is allergic and who is not allergic. And these are the overall results. So this graph is showing the percent of kids with peanut allergy at 5 years of age. On the left bar, we see for the children who ate no peanuts, they had an allergy, a peanut allergy at a rate of 17.2% at 5 years of age. Whereas if the lottery or the randomization had told them to eat peanuts from infancy, the proven peanut allergy at 5 years of age was only 3.2%. And we talked about these separate groups. And so if this slide shows that these are the kids who had those totally negative peanut allergy tests, so no bump when they had the peanut scratch test. And for these kids, if they avoided peanut, then 13.7% of the kids were allergic at 5 years of age, and only 1.9% of kids were allergic if they'd been eating the peanut. Then the next one shows what about the kids who had those small positive tests when they were infants. And these results are also very impressive. The children assigned to eat peanut were much less likely to have a peanut allergy at 5 years of age. And the numbers here are if the child avoided peanut, then 35% of them were peanut allergic at 5 years, whereas if they had been asked to be eating peanuts, then 10.5% were allergic. And I do want to mention that these kids had small positive tests. The children with large positive tests were not enrolled in the LEAP study. It was only children with negative testing or those small positive tests. The kids with large tests weren't part of this study. Great. So I think it's helpful to talk for a minute about the hierarchy of scientific evidence, especially because that LEAP study has been so important to the new infant feeding guidelines. I mean, really, it's the basis for the new guidelines. So the LEAP study is what we call a randomized controlled trial, and therefore, whether the child ate peanut or not was totally under the control of the researchers. It is the highest single study evidence that we can have for a recommendation. And really the only way to have more evidence would be for another group of researchers to complete a very similar trial and then to put the results together. So the previous recommendations to avoid were based on expert opinion, which you can see is very low on the hierarchy of scientific evidence. But why would feeding peanut to infants reduce the rates of peanut allergy? And the idea behind this is what's called the dual allergen hypothesis. So this idea or hypothesis of why feeding peanut to infants reduces peanut allergy is summarized here. The idea is that if a food is eaten, then it leads to an immune mechanism of tolerance or not reacting to the food. The body was designed to eat lots of different proteins, and introducing a food through the oral route or through the mouth and going through the gut would be the natural way for the immune system to first see a food. However, if the peanut is seen first through inflamed skin, such as skin with severe eczema, it could be perceived as a threat and stimulate the immune system, which leads to allergy. And this is what's called the dual allergen hypothesis. So can these children ever stop eating peanuts? You know, if we go ahead and introduce peanuts in infancy, can they stop? So the LEAP study lasted for 5 years, and these kids were followed for another year after the study finished, and they were asked to avoid peanut for 1 year. This is called the LEAP-ON study, and they found no significant increases in peanut allergy. Now, to be conservative, the guidelines, which we'll talk more about in a few minutes, do recommend ongoing exposure to peanut to minimize the risk of peanut allergy in those babies who can eat it. And this is because we really don't know for every individual child how long they need it to be in the diet to not have the allergy come back again. You know, this Leap On study did do a year, but what if they'd avoided for another year? You know, we really don't know. So the advice is to introduce peanut and keep eating it. So what are other foods? And this has been investigated. The same investigators did a big study called the EAT study, and they tried to introduce many foods at an early age. And there did appear to be some benefit for this, but it was very hard for the families to keep feeding all the foods frequently that they had introduced. So the results weren't as strong as the LEAP study, and not everybody was able to do it. So they had less people that actually, you know, followed the early introduction. And then there are other studies that have looked at many other foods, and overall, peanut and egg appear to benefit from early introduction. Fish might as well. And certainly none of the studies have shown any increase in allergy by introducing early. So overall, there's the strongest evidence is for peanut, and some foods may benefit more than others, but we'll just go to the next slide. The best evidence for early introduction is with peanut. And the NIAID guidelines are for peanut specifically. So this is a little cartoon break where she says it was widely reported this week that 8 out of 12 parents believe they prevented food allergies in their children by breastfeeding, by not breastfeeding, avoiding nuts, or eating dirt. So this cartoon shows that parents naturally think about how their actions affect their kids, and we know that many parents of kids with allergies already feel guilt about what could have been done or not could have been done. We just want to say parents did not cause their children's allergies. We all did the best that we could with the knowledge that we had then. And we know that some kids in the LEAP study did have some reactions to peanut on first exposure. They tended to be mild, but the point is there were some kids, even as an infant, who were allergic already. And so not every child's allergy could have been prevented by early introduction. And additionally, even if we had done early introduction, 15, 20 years ago, would we have known to continue it in the diet? Would we have known to be eating it on a routine basis for years? We really just don't know what would have happened. We didn't know this information then, and we're just trying to do the best. Everyone was trying to do the best they could with the knowledge they had. So now we do know this. In 2017, how can we help prevent peanut allergy? So we know from that LEAP study you can reduce peanut allergy by feeding peanuts to babies, and these guidelines help with how to do it. So the guidelines suggest 3 risk groups for infants. They divide them into either a baby that has no eczema or egg allergy at all, a baby that has mild to moderate eczema, or a baby that has severe eczema and or egg allergy. And so when we look at these children, for the no eczema or egg allergy and the mild to moderate eczema, we would really expect most children to fall into those categories. And for no eczema or egg allergy, the advice is to just introduce peanut-containing foods at an age-appropriate time in accordance with family and cultural preferences. For kids with mild to moderate eczema, then they're recommending to introduce peanut-containing foods at about 6 months. And for severe eczema or egg allergy, the NIAID guidelines recommend strongly considering allergy testing prior to peanut introduction, because although this is not all that many infants, these are the ones that are at the highest risk of being peanut allergic at introduction. So we'll just take a minute and talk about what is severe eczema. So severe eczema is persistently or frequently occurring eczema. And the feeding guidelines recommend that it's severe as assessed by a healthcare provider. And they recommend that that means requiring frequent need for prescription strength steroids, calcineurin inhibitors, or other inflammatory medications, even though you're using the creams and ointments as much as you should. And they define egg allergy as a history of an allergic reaction to egg and a positive allergy skin test or a positive oral food challenge to egg. So again, the majority of infants should be advised to introduce peanut at home. And again, it is only this high-risk group, the egg allergy or kids with egg allergy or severe eczema, in which testing is recommended to be considered. So I think this is our busiest slide. Don't worry, it's not, it doesn't keep getting busier from here. But for this audience especially, there may be a lot of parents who may have a child that has the eczema or egg allergy or both, and I think it's helpful to go through what they do recommend for that higher risk group. So for infants with severe eczema or egg allergy or both, you and your doctor can have some guidance about how to proceed with safely introducing peanut. Doctors can use allergy tests, the blood test or skin test, and help guide the peanut introduction. So on the left, we see the blood test. If the blood test shows no allergy, then there's two options to be considered. They could have the peanut introduced at home or a supervised feeding in the office. If the blood test is positive, they recommend for the infant to see a specialist for evaluation and skin prick testing. On the right, we see how the skin test can help guide peanut introduction for these infants with egg allergy and or severe eczema. If the tests are extremely high, we'll move from the right. If the tests are extremely high, we know that peanut allergy is likely, and therefore the risks and benefits of whether to try peanut in a medical setting or to just make the diagnosis of allergy and avoid peanut will need to be considered. But otherwise, for the smaller testing, if you look at the 0 to 2 millimeters, for example, the risk is very low. And the recommendation there would be to introduce peanut at home or a supervised feeding in the office. And for that middle range, this 3 to 7 millimeters, they recommend that the options could be a supervised feeding in the office or consider a supervised feeding in a slightly more acute setting like a hospital setting, for example. Now, we mentioned it just briefly earlier, but again, the very observant people in the audience, which I'm sure there are many, many, will have noticed that these guidelines talk about skin test sizes which were not mentioned in the LEAP study. So kids with greater than 4 millimeter skin prick tests were not in the LEAP study. But these guidelines chose to have a greater than 8 millimeter skin prick test or equal or greater than 8 millimeter skin prick test, to really consider the very high risk group and to have the 3 to 7 millimeter children have either observed feeding or observed feeding in a hospital. And the reason they wanted to do that was because they really want as many infants as possible to have the opportunity to gain from early introduction of peanut. And we do know from some other studies the idea that the larger the skin prick test, the more likely that you are allergic. So this ended up being how they wanted to balance the risk and benefit of early peanut introduction. So again, home introduction will be recommended for most infants. And the feeding instructions are very, very detailed in the document, which is available on multiple websites, including the Food Allergy Canada website. And these instructions can be provided to an infant's parents after the evaluation as to the risk of peanut allergy. That's how they were intended to be provided. So here's some of the advice. The infant should be healthy and not ill. And the first time you give peanut, it should be at home, not at a daycare or a restaurant. And other solid foods should have been introduced first. This is an interesting point. You don't want to pick peanut as the very first food because sometimes infants have just trouble with textures or other things, and you really want to be confident that they can already tolerate solid foods before you try peanut. The other thing that's really important that they spend quite a bit of time on in the guidelines is the style of peanut or the texture of peanut that you give, because infants can choke on whole peanuts, so we cannot use whole peanuts, but even very sticky peanut butter. So we do recommend following the preparation instructions carefully. And then, of course, to stop if symptoms of hives or rash or any other allergy or symptoms appear. They further recommend dedicating a few hours to feeding the peanuts. So we'll just talk a little bit more about how they recommend it, and they give 4 options for how to prepare the peanut. But here's one example where they advised 2 teaspoons of peanut butter, which is about 2 grams of peanuts. And then you add a few teaspoons of hot water and stir until dissolved and well blended, and of course let it cool. And then you can mix it in another food, such as something that you already know they eat, or you could feed it on its own. So you would prepare the appropriate form of peanut and then feed it to the infant, starting with just a little bit on the tip of a spoon, and then wait. So they advise waiting 10 minutes. And then if there's no symptoms, then to continue to feed at the infant's regular pace. And then once peanut is introduced, to continue to feed about 6 to 7 grams a week. So what about reactions to peanut? So the very few of the infants advised to eat peanut at home are expected to have a reaction, and then a severe reaction would be even more unlikely. But of course, you can never have a guarantee. So if there are any concerns about the response to peanut, then the advice in those guidelines are to seek immediate medical attention or call 911. So I said that these guidelines and a summary for parents and caregivers are available on the NIAID website. They are also available on the Canadian Society of Allergy and Clinical Immunology website, and they are also available on the Food Allergy Canada website. We've also added a bit more information just for those that are interested in hearing more about the LEAP study or about eczema. These are great references. So another little cartoon break. Certainly I know when I speak to my mother, I always hear that when she was my age, there were no food allergies. And so we hope for the cartoon on the right, which is that when I'm speaking to my grandchildren, I'll be saying, you know, when I was your age, there were food allergies, and they'll look at me like they don't know what I'm talking about. So thank you so much to Food Allergy Canada and the Canadian Society of Allergy and Clinical Immunology. And Lori is just going to compile some of the questions from the webinar that you've been sending in.
Okay, thanks very much. So there were Sorry about that, folks. So thank you, Dr. Upton. Fantastic presentation, really, really helpful. There have been a number of questions that have come in, but we also prepared in advance questions that came in that were quite common from the registration form. So I'm going to turn it back to Dr. Upton to go through about 4 of them, and then we're going to get to the questions that have been coming through the chat function.
Perfect. Thank you so much. So yes, this is a common question that we've had. What if there is a peanut allergic person in my home? And so those NIAID guidelines do reference this specifically, and essentially it's a case of balancing risks and benefits. You know, you need to think about the family situation and the possible risk of accidental exposure versus the early introduction giving a reduced risk of peanut allergy in the infant. And so we've heard from quite a few people that one of the ways that they have introduced peanut to a younger sibling would be to feed the baby when the older sibling is out of the house, such as at daycare or at school, or to feed the baby at a relative's house. Again, knowing that there needs to be ongoing exposure. Feed the baby while the siblings are occupied, or other ideas that people have had. And really the ingestion, the risk to the peanut allergic person in the household is that of ingestion. And that would be the main part that you would want to take care about. So hand washing and making sure that the peanut isn't available for ingestion to the allergic individual. And another question, of course, that we've heard about is, well, what if my child already has a peanut allergy? We've heard a lot from people that the way that these guidelines were disseminated in the media made it sound like there was now a cure for peanut allergy, and people would get excited for their child with an existing allergy and then realize that really this is a prevention document that doesn't apply to, you know, your 10-year-old with a peanut allergy, and that was disappointing for many people, of course. And so the standard advice for somebody with peanut allergy is to avoid peanut and, of course, to carry an epinephrine auto-injector. But I do want to say that many possible treatments for peanut allergy and other allergies are being actively investigated. So although it's certainly not the topic of today, I don't want to leave the impression that that there isn't work going on for kids that already, or adults that already have an allergy. And this is an excellent question that we've had. So will feeding peanut at 4 to 6 months prevent all cases of peanut allergy? And you saw from the LEAP study that no, it won't prevent every case of peanut allergy. For one thing, there are some kids that are already allergic to peanut at a very early age, and they did tend to have very mild reactions when they were first introduced peanut, but they were already allergic. Now, it should reduce the number of children overall with peanut allergies, but you can't guarantee that it will work on an individual basis. We've also heard people tell us that they actually did feed their child peanut in infancy, and then they still became allergic. And why did that happen if this dual hypothesis is correct, or if any of this was correct? And again, you know, some children are already allergic, so some would have reacted at the time. But also some children may develop the allergy after peanut ingestion if there's not enough peanut in the diet. And certainly we don't know how much is enough for every child, but that's why the NIAID guidelines is targeting 6 to 7 grams a week. So, and they are saying that for for infants who tolerate peanut, that the regular eating is recommended to keep up this tolerance.
All right, thank you very much for those responses, Dr. Upton. We've had some more come in, and we wanted to ask some questions. Some of them are going back over some of the information that you covered, but we've had a few of the same questions come up, so I wonder if you wouldn't mind just talking to them again. So people are wondering if they should speak to their allergist or their child's allergist before introducing peanut to baby. There are people who have kids that have milk allergy, for example, before, and they're a bit worried. What should they do?
Thanks, Lori. So it's a great question. So certainly the guidelines really only recommend that high-risk group are the infants who have severe eczema or egg allergy to be the ones that should consider testing before introduction to peanut. There is not specific advice for the other groups, other than we know that they haven't been flagged as the highest risk category in this guideline, and that it is thought they will benefit from early introduction. So really according to the guidelines, the families that need to speak to their doctor about introducing peanut to their baby are those infants who have severe eczema or egg allergy. And hopefully, for those kids, most will be able to see an allergist. Not every child will be able to see an allergist, and that's why those guidelines put in the IgE testing for some kids who can't get to an allergist as quickly as we would like, you know, maybe in more remote areas or other things. But you can see that even with the positive IgE testing, it would then lead to skin prick testing. So ideally, you see the allergist first if you are somebody who is flagged as high risk.
Thank you. So in terms of, again, some tips for families, there are a few questions that have come in from parents who have peanut allergy themselves. They've got a first child with peanut allergy or someone else in the family, and they're worried. Could you just go over that again in terms of how they should do that safely when you've already got someone with the allergy in the family, please?
Yes, thank you so much, Lori. So certainly the risk to the peanut allergic person is that of ingestion. And different different families have different comfort levels of how they manage that risk of ingestion. So there are some families who will want to create a situation where the younger sibling eats it outside of the house. Ideally, for the first introduction, it should be in the home, but for the ongoing ingestion, some families will choose to, have it at a grandparent's house or somewhere else outside of the home. Whereas other families might choose to do it differently. They might choose to distract the other sibling, or to just eat it at a different time, or even eat it at the same time, but just be able to manage that risk of ingestion. So it really comes down to being able to manage that risk, and different age groups, different family dynamics really do depend on what is the right way for you. And we don't tell you exactly how to do it, other than there is a benefit to it that needs to be balanced against how does that work for your family.
Thank you. So the next question is, how do the guidelines fit with Health Canada guidelines where feeding starts at 6 months? There seemed to be some confusion with parents being told different things by different groups. Could you comment on that?
Yes, that's an excellent question, because it's actually a big problem that many of the guidelines have different complementary feeding times. So some say 6 months, some say 4 to 6 months, and definitely everybody agrees that they need to be harmonized. One of the challenges is that they're written for different reasons. The allergic prevention tends to be written for 4 to 6 months, or starting at 4 months, whereas when you're discussing world feeding guidelines, they do like to promote breastfeeding as long as possible. So there is some challenges to have one guideline for complementary food introduction that works for everybody. But yes, it is a challenging situation that the guidelines don't all harmonize, and that's why sometimes we just sort of say around 6 months is when you should introduce it. And we do accept that it's frustrating to be told different things from different people.
So I can understand this as a parent who has 2 kids. So my oldest son is 22 and my daughter's 19, and the first child did become peanut allergic. So this person's asking, if I had given my son peanuts at the age of 6 months, would we know if he wouldn't have developed the nut allergies?
Yes, so again, that's an excellent question, and we do not know on an individual basis for that child what would have happened. All we know is that statistically, eating peanut early will reduce the children with peanut allergies, but we don't know what will happen to an individual child. And we did touch on that a little bit, but I agree it deserves more time, because we do not want to leave the impression that it's somebody's fault that there was food allergy, or somebody's fault that there isn't food allergy. Or it's really everybody did the best that they could with the knowledge they had at the time. And if we're talking about something 10 years ago or 15 years ago, again, even if it had been introduced, how would you know to keep it in the diet? And we really unfortunately just can't second guess what happened back then. All we can do is try to take these findings from the LAPE study and move forward with them as best as we can.
Thank you. That makes me feel a bit better. So another question that's come in is, what do I do if my baby has a reaction? Can you go over the symptoms again about what I should look for?
Yes, thank you. So allergy symptoms typically develop within minutes of eating a food. It can occur up to 2 hours after ingestion, but typically it's quite quick, which is why those guidelines for the lower risk kids do recommend to just feed a little bit and then wait 10 minutes. So the signs and symptoms could be really mild, such as a new rash or a few hives around the mouth, or more severe symptoms could include swelling of the lip or eyes or face, or vomiting, or lots of hives, or breathing symptoms like coughing or wheezing, or difficulty breathing, or a change in skin color, or sudden tiredness or seeming limp. And obviously this is a huge list of symptoms that I hope you're not writing down. They are in the the guidelines. They are in the NIAID guidelines, as well as there's a lot of information about allergy and anaphylaxis on the Food Allergy Canada site. And so if there were any concerns for severe reaction or allergic symptoms, then you would stop feeding the food and seek medical attention and call 911. And again, you know, the kids who are being advised to eat the peanut at home are thought to be at a low risk of reaction. And just according to the LEAP study, even those that did react at first exposure did tend to have a mild reaction. So of course it's a possibility to have a severe reaction, but it would be unlikely.
Thank you. So again, this is a question that refers back to one of the things that came up, and I think you did talk to it. The question is, how do you proceed if an infant has a known peanut allergy once peanuts are introduced? I think what you said is you don't feed them peanuts. You don't want them to have a reaction. So.
Right. So yes, of course, that's an excellent question. If the infant has been introduced peanut allergy at a young age and appears to react, then yes, you would stop the feeding, and then you would need follow-up with, you know, an allergist to advise the plans from there. I mean, typically the standard of care currently is to avoid and carry an epinephrine auto-injector. In the future, though, and this might be the near future, there may be other treatments for existing peanut allergy. But certainly in the context of these guidelines, we're talking about introducing peanut in infancy. Most kids will be able to eat it and keep eating it, and it should reduce the overall rates of peanut allergy. There will be some kids who are allergic at first exposure, typically with a very mild reaction, but then they would need to avoid and speak to their allergist about, you know, are there any other possible treatments?
Okay. Dr. Upton, this is maybe not so specific to this webinar content, but someone's wondering if there's a standard age for infants to be eligible for skin prick tests or blood testing. Apparently some physicians don't refer kids before 12 months of age, and just as a general comment.
That's an excellent question, and you're right, there can be a hesitation for the primary care doctors to refer. There is no lower limit age for the skin prick testing. And I hear what you're saying, though. There are definitely some doctors who think that we can't do skin prick testing less than a certain age. But, you know, in these studies, the testing was done, in the LEAP study, for example, the testing was done between 4 and 11 months. And so they're in those high-risk kids, and remember those are the ones with severe eczema or egg allergy, then the skin prick test can help to decide what is the safest place for peanut introduction, and or is the test just so large that we should just presume that they're allergic? And, you know, hopefully that won't be very many kids that happens to, because what we really want to strive for is being able to do early introduction for as many kids as possible. I hope that the dissemination of these guidelines will help to get the infants the allergic referrals and the care that they need at this time, and hopefully parents can, because it's so accessible as well for the parents, hopefully that can help them get the referrals.
Thank you. So one parent's asking if you suggest allergy testing prior to introducing peanuts if the child already has an allergy to cow's milk.
Great, so thank you again. So, you know, today we're talking about the guidelines predominantly, and in the guidelines, the children who are considered high risk for peanut allergy are those with egg allergy and with severe eczema. These questions are not covered by those guidelines, and so they're not considered in that highest risk category, and the high risk category was derived from those previous studies. So if you have ongoing questions on, you know, an individual basis about your child, then I would suggest that you discuss it with your doctor or with your allergist.
Okay. So some of the parents are now expecting, and we have a question from a mother who's saying that their first child has a peanut allergy and they're now pregnant with their second child. Do you think it's worthwhile or beneficial to eat peanuts or peanut butter while pregnant to provide exposure to the second child?
Yeah, so that's an excellent question. The advice for peanut feeding in pregnancy is not as clear as this advice. So I would suggest that you do what you like in pregnancy. The evidence for early introduction is extremely strong, for once the child is born. So that is something that we can really recommend on the basis of evidence. But for pregnancy, there's not really any clear advice, and you should do what you'd like to do.
Okay, thank you. And we were talking about this before, like people are interested, like this study's gone on for 5 years, then it had the leap-on study for another year. I guess the doctors will be, or the research will be continuing to follow this with future research?
Yes, they are. So the LEAP investigators are the same as the LEAP-on investigators, and they are following a subset of those kids longer term. And there has been other studies about early introduction. There's, I think, back in slide 29, I referenced that there is a recent study that sort of summarized all of the previous studies on early food introduction. And yes, there are ongoing studies for early food introduction. Basically, the best evidence for early introduction is peanut, but there is no evidence to delay other foods. And I know that sounds a bit like what we said back in the previous guidelines, but the point though is that there is no evidence to delay allergenic foods, and there is excellent evidence for early introduction of peanut.
Thank you. And I think that was a really important slide that you showed on the evidence level, because some people are wondering, because they were told what they felt was the opposite, that this is a different recommendation. So that's important. And I think it's important too for everyone. And as a mother of a child with peanut allergy, my son is now 22, we understand the frustration. It is hard because it's not going to help him, but in my personal situation, the upside of this study for me is that maybe this information is going to go on to help him one day when he decides to have babies, and introduce peanut early to prevent peanut allergy from developing in his own baby. So granted, again, it is disappointing for many of us, but hopefully it'll help peanut allergy from developing in families today, in their babies today, and somewhere down the road for my grandkids.
Yes, you're absolutely right. It is a change in recommendations as we went through, and there's no doubt that that's frustrating. The only sort of consolation, if it is one, is that this advice is truly based on really the highest level of evidence. And if you remember those graphs, the reduction in peanut allergy is quite dramatic with early introduction. And that was based on those observations that they had made from the kids in Israel and the kids in the UK. So there really is very good evidence that this is beneficial. And I know I think we all wish we'd known it earlier, and we hope we can move forward with it now and help reduce peanut allergy now.
Okay, thanks, Dr. Upton. Just a general question, and I know we get that from our families as well. Is there higher risk for peanut allergy in an infant if there's already a sibling, an older child with peanut allergy, or another family member like the parents or the mother or father?
So there is a higher risk in siblings and within families. Certainly the highest risk is the severe eczema and the egg allergy, and that's why that particular group was singled out for this study and for these guidelines.
Okay. I'm not sure if this came up in the guidelines at all, but are you aware of any similar studies going on with dairy or other allergies? This person's not specifying whether it's introduction. It's not totally clear. I'm not sure if they're talking about oral immunotherapy maybe. If I know that there are some trials going on where the kids are being fed milk, for example, or peanut, but I know that there's a government website where people can look at studies. We don't have it right now on our website, but we can certainly give it later if people want to find out what studies are going on.
So to me, this question speaks to a question that I've had a lot of, which is there does seem to be some challenges in discriminating the prevention studies from the treatment studies, and it is hard because we're both of them are talking about eating the food, and again, for these guidelines for today, the NIAID guidelines are really talking about feeding peanut early, and if the child is not allergic, to keep eating it. If the child is allergic, then they're recommending basically it's standard of care for now, which is to avoidance and follow up with your allergist, and then you can learn with the allergist what other treatments there are for the active allergy or for a diagnosed allergy, which at this time the typical advice is to avoid and carry an epinephrine autoinjector. In terms of is there research going on for children with existing allergies? There is for multiple foods. And is there research going on for the early introduction of other foods? And again, there is, including, I think I said on slide 29, I reference a study from JAMA that really summarizes all of the previous early introduction studies. So there is a lot of active research both on the prevention end and on the treatment end, and I would hope that the take-home message really is that early introduction of peanuts at home is right for most kids. There's a higher risk group that does need to have a physician evaluation, and that there's no evidence for delaying of any of the other foods. There just isn't as strong evidence that it makes such a preventative effect.
Thank you. Here's another one, but it's not specific to the guidelines themselves. It's about the presentation, and someone's wondering if the presentation slides will be available. The slides won't be available, but we will be posting the webinar afterwards. So it will be archived so you can see, and we will also be providing an FAQ as well. Okay. Dr. Upton, the other question that we have is, why is egg allergy, why was it considered like a risk factor in the guidelines or in the study itself versus like milk allergy?
Yeah, it's a great question. I mean, really, for many years, studies have shown that egg allergy is a very strong risk factor for peanut allergy. It gives a much higher chance, or we often call it an odds ratio in physician speak, but basically it gives you if you are known to have an egg allergy, you are at a much higher risk of having a peanut allergy. So that's why that particular one was singled out.
Thank you. And someone's wondering if these guidelines have been widely endorsed in Canada, for example, by the Canadian Pediatrics Society, Health Canada. They were wondering if family physicians know about them as well. I know when there was a lot of media attention around this in January, the Canadian Pediatrics Society did talk about them as well. We also had that joint statement from them years ago. But in terms of the family physicians, I guess the question is, are they aware of the new guidelines as well?
It's a great question. I mean, the definitely knowledge dissemination is a challenge in all of medicine, and certainly the 2013 guidelines that I had presented, that was a joint statement of the Canadian Society of Allergy and Clinical Immunology, as well as the Canadian Pediatrics Society. And at that time, in 2013, the advice was no evidence that delaying the introduction of any specific food beyond 6 months helps to prevent allergy. So certainly that society is on board with the knowledge that there's no evidence for delayed introduction. And again, in that guideline back then, they also said that they knew that these that early introduction was actually under investigation for its preventative effect. So, that's going to be the next challenge, and the authors of the LEAP study know that, and so do the authors of the NIAID guidelines, and that's, one of the reasons we're doing this today is to hope to try to get this information out there. It is, it's a big challenge to get the information to everybody that needs to know it, and it's another reason we thank you for coming today.
All right, one final question, Dr. Upton. So someone's wondering, how would a parent know if their young baby has an egg allergy? So maybe you could go over signs and symptoms again and what they should do if they suspect their baby's egg allergic.
Yeah, so the definition of egg allergy according to these guidelines is that the child has eaten egg and had a reaction, so meaning hives or swelling, and that's been followed up with a positive skin prick test, so diagnosed egg allergy by their doctor, typically an allergist, or that the child has had an observed oral food challenge where they're known to be allergic to egg. So the definition is quite tight in this guideline, that it's really a known, essentially physician-diagnosed allergy to egg. So I would need to advise that, if you have a concern about whether your child is egg allergic, that you discuss it with your doctor.
Thank you. So that's all the time we have for questions today. So thank you very much. We hope that this information was informative. Again, in the near future, we will let you know when the information, meaning the archived webinar, is available for you to review again, as well as frequently asked questions that will go along with it. There were many people who were involved in the production of this webinar and the slides, and I'd like to thank Dr. Julia Upton, obviously, Dr. Edmund Chan, Dr. David Fisher, Dr. Elisa Abrams, and Dr. Kyle Hildebrand from the Food Allergy Canada team. Behind the scenes, we've got Ranjit Danjal, Kyle Dine, Jane Holden, Laura Bantock, and Joni Huang. On a parting note too, I know that sometimes it can be very difficult to live with a food allergy. Again, as I mentioned, my son Julian is 22. He's allergic to peanuts, tree nuts, shrimp, split peas, soy, and other legumes. So certainly I get what people are feeling today, but take heart. This is very good news for many babies, hopefully, and hopefully for some of our grandkids as well. If you've got children already with food allergies, there's so much information out there, and we encourage you to go to our website, foodallergycanada.ca. People can live well, kids can live well and normally with food allergies and sticking to specific risk reduction measures. I know that you all know that, but we thank you again for your time today. So we have a favor to ask of you, and that's to take 5 minutes, and we'll be sending you out shortly a very quick survey which you can do online, because we like to hear from you, our audience. We like to know, how did you find the information today and the format? Are there other questions that you have? And what did you think about today's presentation? So please take the time to do that. If you feel like it's a presentation that others would like to see, again, we are looking at having it reproduced by another allergist in another part of the country as well, and possibly in a different time zone. So thanks everybody for your time today, and enjoy the rest of the day.